Hello and welcome to Pupillometry and NPi in the Neuro ICU. I'm Kate McClure, a clinical specialist with NeurOptics. I also work at San Francisco General Hospital in the Trauma and Neuroscience ICU. I am quite passionate about pupillometry because we've been using it for so long at San Francisco General. It's an inherent part of our practice. And not only do I care about the science behind it, I have seen how it directly impacts patient care. What I hope to convey in today's presentation is how and why it's beneficial to management of neuro patients and the best way to make pupillometry effective and valuable at your workplace. With that, we'll get started. A couple learning objectives for today. First, to review why we look at pupils in the first place, what they tell us about the brain. Second, what are the clinical benefits of pupillometry and the neurological pupil index in neurocritical care patients? Many of you most likely have been using the device for years, and in that time, lots of clinical research and evidence has come about further supporting the science, so I'd like to share some of that with you today. As an introduction for those of you who are new to pupillometry, and a review for the rest of you, the pupillometer is a simple handheld device that provides accurate, reliable, and objective pupil data independent of the examiner, and I'll talk about why that's important later. Most importantly, the pupillometer expresses pupil reactivity numerically so that both size and reactivity can be trended for changes just like other vital signs. And what I really want to focus on today is the most effective way to use the pupillometer is to get the earliest possible baseline and trend for changes with each neurocheck. Every patient throughout critical care typically undergoes routine neurological exams, and in fact, this is well supported in best practice recommendations. For those of us in the Neuro ICU, we have the potentially unfortunate luck of having to do these exams much more frequently. I know I'm stating the obvious here, but I have to emphasize why the neuro exam is so crucial. Ask any neurologist or neurosurgeon, and they'll tell you, yes, the exam is always more important than imaging, invasive monitoring data, surgical visualization, etc. Changes in the exam is what guides our management of these patients. It's what helps providers make clinical decisions, first and foremost. We are talking about the most complex organ of the body, and of course, its many structures and functions, and lots of different things that can go wrong. Furthermore, it's not as accessible as other organs. Take the heart, for example. We've got an array of vital signs and numerical data that we can get simply by slapping leads on the chest, measuring blood pressure. The physical examination is easier to perform. We get a lot of clues about hemodynamics just based on that physical assessment. There's lab values, more tests, more imaging, etc. Not the case with the brain. When it comes to examining the brain, we don't have as many tools. And so we're stuck with this, at times, sort of tedious, rudimentary neuro exam. Many parts are subjective, often just simply testing the presence or absence of a cough or gag, for example, which doesn't give you a lot of information about the degree of injury. It's not often cold, hard data that we're dealing with when it comes to neuro assessments. We're really reliant on the exam to tell us if the patient is changing, and that exam has its limitations. Further challenges, as I mentioned, we're talking about the most complex body system. For one, many parts are subjective. The strength of a motor response, say, is up to the opinion or the expertise of the person examining. And that's where we run into the problem of inadequate inter-rater reliability. I think GCS is a good example of this. Two clinicians may score a GCS differently, maybe depending on their interpretation of localization versus flexion. Results at times can be inconclusive. We note an exam finding, but aren't sure what to do with it. So we shrug our shoulders and just continue monitoring. There's limitations to different parts of the brain that we may try to examine, and this is especially true in the ICU population when the patient may be altered or comatose because of their primary neurodiagnosis, or of course they can be sedated, intoxicated, etc. So all of these make our jobs difficult. I think we can all acknowledge the frustration of Q1-hour neurochecks and the tediousness of working in a neuro ICU. Maybe why our friends and colleagues in other ICUs question our choice of field. But we have to accept that the frequency and accuracy of the exams is crucial because unfortunately, if we miss something, we know it can have a detrimental effect on patient outcome. And others are relying on our ability to examine accurately because, of course, the physician or the advanced practice provider is not there to test the patient every hour. They're dependent on you and your exam. We're always looking for ways to make our exam more accurate, easier to obtain if possible, and consistent between examiners. So let's look at why the pupillary assessment is such an important part of the neuro exam and why we were limited by manual assessment methods. So we think of the pupils as the window into the brain. It's an easy, non-invasive, quick assessment, does not require a lot of skill to perform. And most significantly, it can be done on any patient, regardless of their ability to participate. Helpful since we know many parts of the more complex neuro exam require a patient to be able to follow commands. And what exactly are we assessing? Well, it's part of our cranial nerve testing, specifically our second and third, the optic and ocular motor nerves. And what I'd like to point out here is where they root in the brainstem. The optic nerve is technically in the diencephalon, and you'll see the ocular motor nerve here at the very top of the midbrain. Notice that these are anatomically superior to many of the other cranial nerves and reflexes that may be lost later with herniation. This will be key when we talk about pupil changes being an earlier sign of neurological deterioration. This is a quick review of the pupillary light reflex. So when you shine light into the eye, that signal is sent via the optic nerve, cranial nerve 2, back to the brainstem. Here it crosses over at the optic chiasm. From there, the impulse returns to the eye via the ocular motor nerve, causing that constriction of the smooth muscle of the iris. Of note, that impulse actually goes back to both eyes, which is why you see constriction in the other eye as well, what we call the consensual light reflex. So you can think of the optic nerve, cranial nerve 2, as being the sensory portion, and cranial nerve 3 being the motor response. We've traditionally tested pupils using a pen light or flashlight, but we've all experienced these limitations. Obviously, there are pupils that are more challenging to assess. Small pupils, dark colored irises, it can be hard to distinguish that pupil border. There are variations in how we assess different light sources, distances from light source to pupil, changes in ambient lighting, and of course our own visual acuity. These can all contribute to variability in our findings. But of course the biggest issue is the subjectivity of the terminology of how we describe pupils. Brisk, sluggish, non-reactive, they do not have a standard definition. It's really up to the opinion of the examiner. Sluggish kind of becomes this catch-all term for any questionable pupil finding that isn't obviously brisk to us. However, by saying a pupil is sluggish, we're insinuating a neurological abnormality in those cranial nerves, which may not always be accurate. Given the importance of the pupil exam, an accurate, reliable assessment is fundamental, but that's not always possible with a pen light. Most clinicians will acknowledge this, and even though that's common knowledge, it hasn't been proven in literature until this study, which was published in 2016, where they looked at inter-rater reliability among practitioners doing pupil exams. 2 independent manual pupil assessments were performed by different examiners, followed by an automated pupillometer exam, all within 5 minutes. In total, they looked at over 2,300 assessments. And investigators found low agreement between practitioners for overall size, shape, and reactivity. And agreement was only fair between practitioners and the pupillometer. But what was most interesting from this study were the results for patients who were deemed to have non-reactive pupils. Less than half of the time did the 2 examiners agree that they were fixed. So this is when you think it's non-reactive, you call a provider in, and they think it's moving, and that's sort of the end of the discussion. But even more astounding, for those pupils deemed to be non-reactive, only 1/3 of them were confirmed to be with the pupillometer. That means that 2/3 of patients who were thought to have lost their pupils still had reactivity that was missed. What could this mean clinically? Well, take a TBI patient that presents to the ED with bilateral fixed pupils. Often neurosurgeons take that info into account, whether or not they would operate on a patient. So how many potential surgical patients are we neglecting to intervene on because we're inaccurately saying that they're non-reactive? This study confirms that there is low inter-rater reliability among practitioners performing manual pupil assessments. It emphasizes that the pupillometer can be the means to improve the accuracy of this important assessment and can help standardize our practice. So with that, let's do a quick device review. Shown here is our latest model, the NPi 300. Pupillometer is a handheld optical scanner. It stimulates pupil constriction with a consistent flash of light. In those 3 seconds that the device is scanning, it takes about 90 images of the pupil. And I'd like to point out that it's evaluating the entire pupillary light reflex. When we look with a pen light, we're really trying to gauge the speed of constriction alone. This is looking at not just that, but other factors as well, from prior to constriction all the way through to redilation. The SmartGuard acts as a positioning guide for usage and can be used multiple times on a single patient. It is embedded with a memory chip, and all the patient's readings are stored on it. There are just a few simple steps for using the pupillometer. The SmartGuard is attached to the pupillometer and programmed using the barcode scanner. After positioning, the right or left button is used to scan the corresponding eye and then repeated for the opposite eye, with results displayed on the device. So let's talk about the data. The primary data point we focus on is the neurological pupil index, which is a calculated value based on an algorithm comparing your patient's pupil data to a normative model. It's grading the pupillary response on a scale from 0 to 4.9. Higher the number, the more brisk the pupil. As it declines, it's becoming more sluggish. Note here that 3 is our cutoff. NPi greater than 3 is considered brisk, less than 3 sluggish, and a 0 is a non-reactive or immeasurable pupil. So here at the example in the bottom, I've got right NPi of 4.1, left of 4.0. These are both greater than 3, so these are considered brisk pupils. A lot of nurses ask me what makes up NPi, and I'll point to these 2 data display screens that the device offers. Here on results screen 2 on the right side of the screen, you see many other data points listed. These are all the pupillary metrics that the device measures that are used to calculate NPi. So things like constriction velocity, percentage size change, etc. You can think of these as pieces of the pie, and NPi is the whole pie. The main takeaway point I want to stress today is trending. We know this device is very helpful to nursing. It makes our exam more accurate. It improves inter-rater reliability, but the only way it's going to help a patient is if we use it consistently. What we're looking for is that downtrending in reactivity as our signal for potential neurological deterioration. We may not be able to detect those subtle changes with the naked eye, and of course with a pen light, those changes are not quantifiable. So the only way we can accurately detect these changes, insinuating potential brainstem compression, is by using it with each and every neurocheck. I already stressed the challenges of accurate neurochecks because so many parts are subjective. Pupillometry adds that valuable objective means to trend an exam for changes. If you're a visual learner, there is the ability to graph your patient's data on the device. Shown here at the top is the icon on the home screen. Once you select that, it'll read the data off your patient's SmartGuard where it's stored. In the middle, you see normal trends in NPi and size, and on the right, you can see a decline in NPi along with an increase in pupil size. To really emphasize the importance of trending, I'd like to review a quick case study from Dr. Yazbek at John Muir Medical Center here in Northern California. So this is a 52-year-old female with a history of hypertension who developed severe sudden headache. She presented to emergency department. According to EMS, she was initially lethargic, but was answering some simple questions and was quite hypertensive. They did a non-con head CT that showed a left parietal intraparenchymal hemorrhage with mild surrounding edema and a 4 millimeter left to right midline shift. So here is her initial GCS in the field when she was still answering questions. And then in the ED, it dropped as she was no longer verbal and was only localizing. So due to her scan and a decline in GCS while in the ED, she is intubated and sedated for airway protection. So she's on sedation. They started nicardipine for blood pressure control and sent her to the Neuro ICU. So the patient gets to the Neuro ICU around 2300. They decide to hold her sedation to do their own examination. They find that she's not following commands, but is purposely moving the left side and is briskly localizing with that arm. So here is her first GCS in the ICU, sort of indicating that she's intubated and localizing. And here is her first pupillometer scan. So we notice right NPi is 4.6, left is 4.4, so nice brisk pupils. Because she's coughing and restless, they turn her sedation back on for vent synchrony. She's ordered Q1-hour neurochecks with pupillometry overnight. So here at 1 a.m., we have her pupillometer readings. We note her right pupil is now 3.4, still greater than 3, so still technically brisk, but that's a pretty significant drop from her previous. And now her left pupil is only 0.9, so we have an abnormal pupil. I also note that change in pupil size and the difference between the two pupils. So because of this, they turn off her sedation again to get a more thorough exam, and they find that she's weakly localizing and no more sort of purposeful, spontaneous movement on that left side. Technically, her GCS is unchanged. She's still localizing. We still can't test verbal, nor is the eye opening really accurate in this setting. So if we're just trending her exam, it's hard to say there's been a significant difference. However, I think all of us acknowledge that there is clinically a difference between brisk localization and a change when it's much more difficult to elicit that same response. So they decide to re-image her, and they find on CT she has rapid worsening of cerebral edema and an increase in midline shift to 10 millimeters. They decide to intervene with mannitol and start her on a hypertonic saline drip, and she's taken to the operating room for an emergent decompressive hemicraniectomy. And here we have her post-op pupil scan. Her right NPi is 3.8, still normal, and her left has recovered back to 4.3. So this is a great example of how the pupillometer was able to pick up on early deterioration in this patient's condition. Of course, in the setting of sedation, we do not have the ability to continuously monitor a neuro exam. So that NPi drop was the warning sign that triggered another sedation hold, imaging, and eventual intervention. So really directly influence management and thus this patient's outcome. For the remainder of the presentation, I'd like to look at some of these key diagnoses that are found in the Neuro ICU and the literature that supports the usage of pupillometry for these patients. And to do that, I think it's important to define physiologically what's happening to a brain suffering from one of these, and to look at things happening on a cellular level after tissue injury. The brain's very reliant on consistent blood flow. Unlike other organs, we don't shunt from the brain. So within minutes of deprivation of blood flow, tissue begins to experience ischemia that sets off these inflammatory cascades. There is a lot going on here, and I'm not going to go too in depth with this, but just as a quick overview, triggered by that tissue ischemia or tissue hypoxia, you have unstable cell membranes with ion fluxes like calcium rushing into cells, causing cell death. You have unregulated neurotransmitter release, free radical production causing vascular damage and vasogenic edema, and then what we call the excitotoxicity of cells. Essentially, all these things lead to further neuronal injury, and thus that translates into neurological deficits. I like to point out all these details because often we chalk up deterioration to swelling, and I just want to note there's a lot more happening than just swelling. We call this response secondary brain injury because it happens as a result of whatever the primary injury is, and it can continue to occur hours, days, and sometimes weeks after the initial injury or insult. This is why our patients deteriorate All of our care in the ICU is trying to prevent and reverse these processes. Since all of that's happening on a cellular level, we can't directly visualize it. These are some of the ways we see secondary injury at the bedside. Fever is a great example. All those processes are heat generating, which is what we refer to as neurogenic fever. We know often these severely impaired neuro patients get febrile, and unfortunately, we keep having to do cultures just to prove it's not infectious. I already mentioned the formation of cerebral edema, both vasogenic from that leaky vasculature and cytotoxic or intracellular edema from the failure of the ion pumps. You can, of course, have delayed bleeding or new bleeding forming, infection, seizures, and of course, if these things are left untreated, they can eventually lead to herniation and brain death. The frequent neuroexam is our main tool at trying to identify whether these processes of destruction are worsening significantly. We don't always know what patients will deteriorate, but if someone wanted them in the Neuro ICU in the first place, that means they require frequent examination. I'm often asked, well, do I need to use the pupillometer if the patient's awake and alert? Typically, I'll respond, if they're awake and alert, do you still have to check their pupils? Or if you've ever had an awake alert patient who deteriorates. This is why I stress the importance of getting a baseline regardless of how they present and trending with each neuro change. We don't want to wait until a patient has other compelling signs of decline before measuring their pupils. Another basic physiological concept I think you're probably aware of is the Monroe-Kelly hypothesis. Simply put, the skull is a fixed enclosed space containing these three components. If one component rises, another must decrease, or else you'll see a rise in intracranial pressure. Even though this concept is pretty basic, I bring it up because it really drives everything we do at the bedside to manage these patients. We're juggling these various components here, trying to keep the brain in equilibrium. And when the brain is unable to maintain that equilibrium, it will begin to herniate. The only release point is the foramen magnum, which is that hole at the base of the skull. The brain can herniate in many different ways, but the two I'll focus on are shown here. Uncal herniation is when the uncus of the temporal lobe starts moving laterally and downward, compressing the brainstem. This is when we see that classic dilated and more sluggish pupil unilaterally from that ipsilateral midbrain compression. And then central is the downward movement of both cerebral hemispheres, compressing the diencephalon and the brainstem. If this is left untreated, that midbrain compression continues, pupils enlarge in size and become non-reactive. This is what we call blown pupils. Both of these are potentially reversible, but they must be caught early. Once the midbrain is compressed, we know ischemia is already occurring, which is going to lead to infarction, and then prognosis becomes extremely poor. We are always trying to detect and prevent this before it happens, and trending of NPIs are a helpful tool to do that. Because cerebral edema, it can form in many different types of neuro patients, I'll share this piece of evidence to start that was published in 2019, looking at the connection between NPI and cerebral edema. This study used the pupillometer to look at the effect of osmotic therapy on pupil reactivity. Over 400 paired assessments were performed on 72 patients who either got hypertonic saline or mannitol for treatment of cerebral edema. Results showed significant improvement in NPI within 2 hours of osmotic administration. Osmotic therapy caused quantitative pupil changes that were independent of other medical interventions to reduce ICP. This is something we see at the bedside commonly. A patient will have a drop in their NPI, which means a phone call to a provider. Mannitol's order, and after it's administered, we ideally see an improvement in NPI. So keep in mind we can also use NPI trends as a means to tell us if our intervention has worked. So the first diagnosis I'd like to discuss is traumatic brain injury, which is my personal area of interest. As a quick review, we classify TBIs by their mechanism and the type and area of hemorrhage that's occurred. Reminder that all of these are primary injuries and they will result in secondary brain injury to neurons that were otherwise unharmed. So if the bullet track through the brain is the primary injury, the surrounding tissue is what we are trying to salvage. Mechanism can tell us more about what to expect with the severity of secondary injury. Those higher mechanism traumas like high-speed injuries, rotational shearing forces, for example, or the polytrauma patient who has experienced an episode of hypotension or hypoxia. Even a single episode of either of those are proven to dramatically increase morbidity and mortality after TBI because we know that will significantly worsen secondary injury. Why do TBI patients deteriorate? Well, we often say swelling, but we know it's a lot more than that. All of these are components of Monroe-Kelly, so if one of them increases, we know we'll have a rise in ICP. So of course, if that lesion continues to bleed and take up space, we talk a lot about optimizing venous outflow in TBI patients. About 2/3 of the blood in the brain is venous, and making sure it's able to clear out of the sinuses is key to reduce ICP. Cerebral edema, of course, we can manage with hyperosmolar agents. Hyperemia is that concept of blood flow in excess of tissue demand, so too much blood going into the brain. And then, of course, disturbances in how CSF is created and circulated. Unfortunately, another component of secondary injury is the breakdown of the blood-brain barrier, which further makes that tissue susceptible to damage. So let's look at the research and see how NPi is helpful in detecting these types of deterioration. So we know the first step in TBI management starts with triage after identification of injury. This recent pilot study that was done at UT Southwestern in a very busy ED looked at the relationship between NPi and patients undergoing a surgical intervention for TBI. They found that NPi was predictive of the need for surgical intervention and was normal in all patients who did not require intervention. I think it's important to note most ED patients do not have ICP monitors yet, so you're not gathering other neurological data points. So a non-invasive pupillometer can deliver that data before they're placed. They concluded that NPi may be helpful in the management and triage of comatose patients after TBI. Higher NPIs were associated with better outcomes, and additionally, a low NPi was indicative of severe brain injury requiring a surgical intervention. Based on these results, a much larger study is underway. Lots of patients present to the ED that are altered. It's difficult to determine, are they intoxicated, psychotic, or are they actually neurologically injured? This study introduced the concept that perhaps NPi can help triage patients with altered mental status. This is a quote from the study's principal investigator, Dr. Ione, who is a neurosurgeon at UT Southwestern, and he summarizes that point exactly. The value of NPi as a means to triage patients earlier and quicker to the best level of care. The second study I'll mention in relation to TBI was this one done in 2019. This study gathered data on 54 patients with severe TBI and a GCS less than 9. Researchers looked at the relationship between non-invasive NPi and invasive ICP monitoring in patients that were at risk for intracranial hypertension. Results showed that abnormal NPi was a marker of severity, of increased ICP, a more complicated course, and a worse 6-month outcome. The study showed that sustained elevations in ICP were associated with a decrease of NPi. Again, treatment with osmotic agents was associated with normalization of NPi, and failure of NPi to recover was associated with a very poor prognosis. There have been many other papers that have looked at the relationship between NPi and ICP, and they again showed that NPi decreases are happening earlier, and in one paper on average almost 16 hours before the peak of ICP. All of this fits with the pathophysiology that we discussed. That increase in pressure can result in downward compression on the midbrain, reflected in that downtrending NPi. As a neurotrauma nurse, I acknowledge the significance of drops in NPi from the patient's baseline because I'm concerned for worsening secondary injury and the potential for brainstem herniation. We treat that NPi drop as our warning sign, and it can often occur prior to other exam changes. Okay, next I'll talk about subarachnoid hemorrhage, which of course falls into the category of hemorrhagic stroke. Both of these involve hemorrhage due to blood leaving the vasculature. usually from damaged or weakened vessels. For today, I want to focus on subarachnoid hemorrhage, and though there are several causes, I'll just focus specifically on aneurysmal subarachnoid. So a rupture of an arterial aneurysm can occur from compromise in the structure of the arterial wall. This releases blood into the CSF, often at high pressures, and this can rapidly increase ICP. Keep in mind, blood is really disruptive and irritating to the tissue, so that stimulates those inflammatory pathways I mentioned. And even after these vessels are stabilized, either spontaneously or surgically, like with a clipping or coiling, the care of these patients focuses on the monitoring of their neurological status and whether their secondary injury is worsening. One of the most common and challenging complications is vasospasm. So cerebral vasospasm is a complicated and not fully understood phenomenon. It occurs as a result of subarachnoid hemorrhage, and it's unfortunately the leading cause of morbidity for these patients. Vasospasm is the narrowing of those large and medium-sized vessels. We often kind of think of it like this hourglass where the vessel narrows to such an extreme degree. So this results in a drop in distal blood flow, which of course can lead to ischemia and thus further loss of tissue and function. Vasospasm can be transient. It can occur at any time over several weeks post-subarachnoid hemorrhage. And the biggest issue with vasospasm is they're difficult to detect at the bedside. You can do transcranial Dopplers and CTAs that could help detect or suggest the presence of vasospasm, but really you need a trip to Neuro IR to do a full diagnostic and have the ability to treat, usually with an intravascular vasodilatory medication like verapamil. Why these patients are challenging? Well, they're usually in the ICU for a long time, often at least 2 weeks while they're in that vasospasm window. We often get very fatigued, as will the patient with the frequent neurochecks. However, we know vasospasm can be devastating and it can occur at any time, and thus, unfortunately, that frequent monitoring is necessitated. So could NPi be beneficial in these patients? These researchers, including the aforementioned Dr. Aoun, investigated the role of automated pupillometry as an adjunct to transcranial Doppler studies. They looked at a total of 56 patients and over 600 paired readings and compared them with their Doppler studies. The results show that 12 of those patients did have delayed cerebral ischemia during their ICU stay, and 10 of those patients had evidence of that vasospasm on transcranial Doppler. A decrease in NPi values under 3 after initially presenting with normal NPIs was strongly associated with delayed cerebral ischemia. And in the majority of cases, that decline in NPi occurred greater than 8 hours to other signs of clinical deterioration. So this study just concluded that adding hourly pupillometry exams to daily Dopplers could provide advanced warning to begin treatment prior to the development of vasospasm, which could lead to that irreversible neurological damage. Next, I will talk about ischemic stroke, an even broader disorder that I'll just breeze over. As a quick overview, these are the 3 subtypes of ischemic stroke. I like to point out that any drop in cerebral blood flow, either to a specific area or globally, is a form of ischemia. So this third category is important to keep in mind, especially in critically ill patients throughout various ICUs. For those of you who work in the trauma world, I also like to mention cerebral artery dissections, like an injury to a vertebral artery. Why those patients require frequent neurochecks due to the concern for a drop in cerebral blood flow from either further dissection or a potential for thrombosis from the injury to the vessel wall. The pathophysiology of ischemic stroke is not dissimilar to the other neuropathologies. Triggered by ischemia, the brain has some compensatory mechanisms, but there is a limit. We know many factors are at play for determining the severity of the stroke, but once that ischemia is set in, we know we're set up for some secondary injury. Strokes can happen in many different regions of the brain, and they may or may not affect the pupils initially. However, there are serious complications that can occur that do potentially affect the pupillary light reflex, and this could happen with any stroke patient. The leading cause of early deterioration is the formation of cerebral edema, often referred to as malignant cerebral edema, and it's commonly associated with those large territory strokes. That large area of ischemia means higher incidence of secondary injury, more inflammatory activity, leading to that breakdown of the blood-brain barrier and formation of significant vasogenic edema. As a result of reperfusion, which is of course always the goal, we can unfortunately have a hemorrhagic conversion. This is especially common after administration of TPA or after an embolectomy. We already know the frequency required to monitor those patients because of the high risk for bleeding. And as with other neurodiagnoses in the stroke population, we don't always know who will deteriorate, who will have that hemorrhagic conversion. But we do know all patients with this diagnosis require a set frequency of crucial neurochecks, and thus the accuracy of our monitoring is key to detect these early changes. Using data from the National Registry, these researchers studied the correlation between pupillometer readings and the midline shift in patients with acute ischemic stroke or intracerebral hemorrhage. Pupillometer measurements were taken within 6 hours of diagnostic imaging. Results showed a statistical relationship between midline shift and pupil reactivity, not necessarily pupil size. And it was suggested that the pupillometer could be a valuable tool for monitoring the worsening of intracranial pathology in patients with stroke. I like this second point here as a reminder. We can gather critical neuro information using the pupillometer that is non-invasive. It doesn't require a neurosurgeon to come in the middle of the night to drill a hole in the head to get some data early on. And then this paper that was published in 2020 looked at the use of pupillometry to identify neurological worsening in patients with large hemispheric strokes. They did over 2,400 exams on 30 patients. And here they found that neurological deterioration was seen in all patients who had a low NPi, here less than 2.8. So patients with neurological worsening experienced a sudden drop of about 30% from their previous, and this at times happened almost 10 minutes prior to signs of other deterioration. So this study validates that an abnormal NPi value is indicative of neurological worsening. I mentioned earlier how historically we've called lots of pupils sluggish because we weren't sure of their reactivity. With the pupillometer, that literature continues to validate that an NPi less than 3 insinuates an abnormal pupil response and requires attention. So this kind of adds value back into the pupil assessment, so now a sluggish pupil should mean something again. And then lastly, I'll speak a little bit about seizure and status epilepticus. Published in November 2020, this is the first study to assess whether NPi is altered in patients with non-convulsive status epilepticus, or NCSE. 103 adult patients presenting to the ED after suspected seizure with failure to return to baseline were examined using EEG and pupillometry. Using established criteria, patients were then diagnosed with no NCSE, possible NCSE, or confirmed NCSE. Comparisons were made for right NPi, left NPi, minimum NPi, and difference of NPi between right and left. Results showed that NPi, right and left, as well as minimum NPi, were significantly lower in patients with confirmed and possible NCSE compared to patients with no NCSE. The side-to-side NPi differences was significantly higher in confirmed and possible NCSE, and also there was no significant NPi difference between patients who did or did not receive benzodiazepines. The study concluded that NPi was lower and NPi difference was higher in patients who had confirmed non-convulsive status epilepticus, and that all patients diagnosed with NCSE were correctly identified by pupillometry. And since many of those patients and patients throughout critical care often require sedation, this is sort of a good segue into a common question about how do medications affect NPi. As I mentioned earlier, NPi is a calculation based on various pupillary metrics. We know meds primarily affect pupil size, and NPi factors in pupil size as it calculates. What that means is NPi is consistent in patients who are on sedation, receiving opiates or benzo infusions, and even paralytics. Paralytics do not paralyze those cranial nerve pathways, so you can at least monitor those patients for pupil changes, especially since if they're paralyzed, you do not have a neuro exam. So short answer, based on the literature, NPi is normal in the presence of these medications here on the right, if that's the patient's baseline. That's why we see pupillometry utilized throughout various ICUs on any patient that's heavily sedated and or paralyzed who's unable to receive routine neuro examinations. To close, I'll talk a little bit about how to incorporate pupillometry into your practice or how to improve usage at your institution. In case you're curious, here are some of the clinical references that support pupillometry. Most recently, the American Heart Association guidelines for CPR and emergency cardiovascular care included recommendations for pupillometry. You may be wondering how many hospitals are using pupillometry, including the majority of the top neuroscience centers in the country have successfully incorporated pupillometry, further proof it's rapidly becoming standard of care. In fact, many centers have adopted one device per room or one device per nurse. This supports optimal workflow and patient care. It is very challenging to do Q1-hour neurochecks if you are sharing a device. I work at a county facility. We have one in every room now, which has allowed the standardization of our pupil checks to incorporate pupillometry. There are a couple ways to guide usage at your hospital, and the first involves the usage of protocols. One of the best protocols we have seen comes from Geisinger, which is a large health system in Pennsylvania, encompassing 7 acute care hospitals. Pupillometries have been adopted throughout and guided by this system-wide protocol that requires a baseline and subsequent pupillometer measurements for all neurologically injured patients. Notice this list includes all the patients I talked about today and which the research supports. We've seen some examples of very successful protocols from other institutions. We can share those with you if you're interested in developing a protocol for your hospital or if you'd like to improve yours. Please let us know. The other way to standardize usage is the use of order sets. Overall, a physician order is not typically required to use the pupillometer since it's an assessment tool. However, order sets are a great way to standardize usage. This set is from Arrowhead, which is a hospital in Southern California, and this is their stroke order set. And you'll notice here they incorporated neurochecks with pupillometry, and they can set the frequency. The every 4 hours here is for their step-down unit, where they also utilize pupillometry to continue to monitor those stroke patients. So the best practice for incorporating the pupillometer, these are the 3 keys to success. First, I can't say it enough, use the pupillometer to establish a baseline at the time of admission on any patient with the potential for or actual neurological injury. Establishing a baseline lets you compare trends over time and helps us detect those changes. Then continue to use the pupillometer for all routine pupil examinations for an accurate trendable assessment. The only way the pupillometer is going to be helpful to patients is if it's used consistently. And then finally, establish clinical protocols for use of the pupillometer helps to ensure the standardization of use. Today we focused primarily on what's in the gray box on the left. There's also growing evidence to support pupillometry in a wide range of patients that are not typically found in the Neuro ICU. The value of pupillometry for these secondary neurological indications will be covered in future symposiums. The NeurOptics website hosts an abundance of scientific support for pupillometry, including peer-reviewed research, publications, and abstracts. On the last count this week, there were over 100 clinical publications to demonstrate the value of pupillometry in a variety of patient diagnoses and clinical scenarios. The body of evidence is growing almost more quickly than we can keep up with. If you'd like to read these, they are available on our website along with many other publications, including all of the ones I mentioned today. We also invite you to check out the NeurOptics website where you can find product information if you'd like to learn more about the device and videos in the section on pupillometry education. If you'd like specific training for your staff, please don't hesitate to reach out to your regional sales rep or clinical specialist to schedule in-services or for further training. And lastly, if you'd like to earn an AACN CERP credit for watching today's presentation, you can scan this QR code here or visit the link to complete the questionnaire. Upon answering 4 out of 5 questions correctly, SurveyMonkey will show you a confirmation screen with the URL to download for your CERP certificate. And with that, this concludes the presentation. Thank you very much for your attention. I am honored to speak on this topic. Thank you also for the care of your patients, for your team, and your community. Thanks, and have a great day.